So I'm going to talk about clinical guidance system. This is a name for a way of using pulmonary rehabilitation tools in the management of patients with COPD, the long-term management of patients with COPD over the life of the patient and the life of the disease. So we'll look a little bit about what the disease is, although Guy presented a great introduction to that. And how does it behave? And what are the characteristics of it as a chronic disease? And what effect does it have on the lives of our patients and actually their families as well? And then come up with a strategy based upon what we're learning here. Come up with a strategy for lifetime management using pulmonary rehabilitation tools integrated into standard care. Now, here's a little animation about what COPD is. Here's chronic bronchitis, where the airways are swollen, they produce a lot of secretions, and obstruction. And here is asthma, sort of an asthma component, although asthma itself is a separate disease. And then there's the emphysemic component, where we focus more of our attention on the alveoli, but how the alveoli don't keep the airways open. Actually, they compress the airways in the case of a person with emphysema. And in this next video, here we have the normal lung, and we have an emphysemic lung, or a lung that is becoming emphysemic from normal. And here we have the loss of elastic membranes of the alveolar capillary membrane that normally would tether the airways open, as in the normal lung, but actually, with that loss of elasticity, we lose the ability to keep the airways open. And here in this particular animation, and I'll keep the arrow or the little hand in the same place. Here's a person with heterogeneous disease, emphysema at the top, more normal lung tissue at the bottom. And as a person tries to breathe more rapidly, like when they're trying to exercise, what happens is that they start to trap air. Air stacks on air. It's kind of like this. If you all take a deep breath, take a real deep breath, and then breathe at the top of that breath. That's what air trapping feels like to the COPD patient with emphysema who is trapping air during exercise. It's their exercise limitation, or their ventilatory limitation to exercise. And what happens is that when they try to exercise, their end expiratory lung volume, they don't empty their lungs, and the lung volume tends to go up, and they trap air. So an obstructive lung disease, in this case, becomes more of a restrictive lung disease because you're lacking the ability to take in a deep breath. Now, of course, the surgeon's credo is if you have heterogeneous disease, when in doubt, cut it out. So, with that. So what happens is they remove the emphysemic portion, and it allows the rest of the lung to expand and take that place, and so the person has actually more breathing room. And so successful lung volume reduction surgery actually gives a person more breathing room. Now, there's another problem with COPD. With emphysema, your lungs fill and empty at a rate that is different from your normal alveoli. So when that happens, instead of the air going in and out of the lung, it actually not only goes in and out of the lung, but it goes back and forth between emphysemic and more normal lung tissue, or more normal lung units. That's called pendulum, by the way. Look it up. Now, the person with COPD, over the time of aging, their disease and their lungs get older and worse. And in the case of the COPD patient who smoked, might end up with oxygen therapy. You'll never look at Mona Lisa in the same way. Now, taking a look at the disease characteristics, the characteristics include airway obstruction and hyperinflation, as we were describing it. And remember, hyperinflation is considered bad. Remember Alan Greenspan telling us that? So, gas exchange loss, deconditioning, muscle weakness, cor pulmonale, exacerbations, or flare-ups. We use the terms interchangeably. And living near the foothills, flare-up has a lot of meaning for us. Disability, hospitalizations, and respiratory failure. Now, if you describe it as we did in the ATS-ERS COPD guidelines, we're looking at the disease progressing this way. Not all COPD progresses in this way, but most of it does. They're at risk. They, at some point, become symptomatic. They develop exacerbations and eventually respiratory failure. Well, we have a big arsenal of care. Just about every aspect of COPD, including the comorbidities, are treatable. Not necessarily curable, but treatable. So smoking cessation, very, very important. Vaccinations for flu and pneumonia. Long-acting bronchodilators, short-acting bronchodilators for quick relief. Nutrition, active lifestyle, exercise, it goes on and on. But our ability to treat these people really is quite good. And we can make a big difference. Exacerbation management. Exacerbations or flare-ups are a reason patients get hospitalized and the reason that some of our patients die. We have surgical options, as I was just describing before, non-invasive positive pressure ventilation, and of course palliative care. That actually starts not at the end of life, but as we start treating these patients. So our clinical philosophy is this, that the disease is chronic and progressive, and all components of the disease are treatable. People can live active lives. Emergencies are preventable, hospitalizations are preventable, and in fact, the clinical course of this disease can be modified so people can live more quality lives. Well, coming from that point of view, we develop a clinical guidance system. That is our management technique. In other words, how do we help these people over the lives of the patients, and how do we integrate it into the standard doctor's office visit, which we call the doctor's therapeutic office visit? Well, we have our goals, as I was just describing, and we do it in a group setting so that patients can help each other and can encourage each other. And so we have support groups that are run by my partner, who is a rehabilitation nurse, who has a lot of background in this sort of thing. Components of care that I described managed into a set of daily rituals, which are the lowest common denominator of the treatment of these people. And it's what they do at home that really makes the difference. And our office protocol mirrors what the patients do at home so that we can monitor them, we can reinforce them, so that we can help them to get better at it. It's practice, developing skills, habits, and routines. Now, the disease progresses like this. FEV1 is a pulmonary function test in which the patient takes a deep breath and then blows out air real rapidly. And how much air they can blow out in 1 second has a lot of meaning to us as people who treat COPD patients. And as the FEV1 decreases, symptoms tend to increase. But there's no real landmark exactly where everything is, but we do develop staging systems that kind of give us some idea. So we develop these clinical landmarks of at-risk, symptomatic now with exacerbations, and some exacerbations that end up as respiratory failure. And we develop a disease management model that takes into account all of these steps along the way in the development and the progression of the disease clinically. So when you develop these guidelines, and of course you go into the ATS COPD guidelines website, you'll see this sort of navigation diagram. And you can actually download a PDF of this, so you can keep it on your computer. And it has all of the hot buttons that you can, the hot links that have on the website, in fact, even more. But here, when you develop a set of guidelines, it tells you what to do. It doesn't really tell you how to do it. So we've got to bridge that gap between scientific and expert opinion and actual disease control. So looking how the disease and how it affects the person's functionality progresses, of course, the lungs get worse over time. Aging will cause the lungs to get worse, but COPD is like accelerated aging. And of course, as the patients become more short of breath, they tend to become less active. And as a result, they get deconditioned. So you add deconditioning layer to their tendency towards getting shortness of breath. And then they also develop increasing numbers and intensity of exacerbations or flare-ups. And so what the patient suffers from is not the lung, not just the deconditioning, or not the flare, but a combination of all three. And we tend to all three, and we can have some effect on all three layers. So when a patient comes to us, they basically are given a choice. You could either let the disease take its natural course, which is not a very pleasant course, or you can live an active lifestyle, actually live the part, and do things that enable you to have an active lifestyle, such as exercise, regular exercise program. And I can tell you right now that the best exercise program is walking. Cut through everything on pulmonary rehab, the best exercise is walking for endurance and strength. Now, so living pattern affect disease control. Now this slide I subtitled, Say No to Crack. Well, of course, job number one is to make sure the patient's not smoking. If the patient isn't smoking, or you certainly have to tend to the fact that they might be exposed to other people's smoke. Now, this horse never smoked a day in his life, but he lived with a Marlboro man. Well, we all saw pictures of Rich Cassavery. He has done some wonderful work in this field and enabled us to understand a lot better what we're doing in pulmonary rehabilitation, in pulmonary physiology, and in pulmonary medicine in general. When a person undergoes an exercise program, it enables them to be able to exercise at the same work rate, but not have to breathe so hard. Well, if they don't have to breathe so hard, exercising at the same work rate, they can even exercise higher. Because what happens is that part of ventilation is how fast you ventilate. And how fast you ventilate makes a big difference. Because if you're ventilating faster, what happens? You trap more air. And as you trap more air, there's more of a ventilatory limitation exercise. So for an exercise program, the inspiratory capacity improves because the patient is able to empty their lungs so they can take in the next breath of air. So they have more breathing room. Well, a couple of studies were done looking at oxygen therapy and survival. These studies were done in the 1970s, both in the United Kingdom and also in the United States. I'm going to give you a combined result of those studies. It shows that oxygen therapy, for those people who are hypoxemic, in other words, need oxygen, if the person didn't take their oxygen, their survival was poor. If they take oxygen part of the time, taking into account two of those studies, then they did better in a sort of a dose-dependent fashion. But if the person exercised, if the person took oxygen most of the day, then what they would do is they would be able to survive longer. But notice that it took a couple of years to see this difference. Well, re-looking at some of the data from the United States version, the NOx study, a person who is inactive and who had oxygen 12 hours a day had a lot of days in the hospital. Whereas if they had oxygen continuously, but they were inactive, they had fewer days in the hospital. And if they had oxygen part of the time, including the hours of sleep, by the way, then, but they were active, had fewer days in the hospital. But if they were taking oxygen continuously and active, they had even fewer days in the hospital. So, more oxygen plus more activities equals fewer days in the hospital. Rich Cassavery's group did another study in which they looked at people who didn't need oxygen by Medicare criteria. In other words, their saturations were not above, not below 88%. In fact, they were well in the mid-90s even during exercise. They trained on room air. They did quite well, but if they trained on oxygen, they did even better. And these final tests were breathing room air for both groups. So in other words, oxygen sort of, in this particular study, not all studies have shown this, but in this particular study, oxygen sort of is an adjunct to exercise to enable a better result from an exercise program. Well, take a look at oxygen transport. This is getting oxygen into the tissues. The lungs are only the introduction. Then you have the circulation, you have the muscle, and oxygen travels through this pathway And this is kind of, I titled this slide "Body Machinery" because it really says that this whole way of getting oxygen to all the tissues and having it utilized by the tissues, in this case the muscles, involves the entire body. Exercise involves the entire body, and exercise involves all three of these gears. And of course, carbon dioxide is the end product, and it goes out the same pathway. So exercise is important in oxygen transport. So now, something else that helps exercise work. Now here is a study done looking at people who had pulmonary rehab, which includes an exercise program. And of course, their ability to exercise was improved by the program as expected. But over time, you lose that, okay? Because people don't keep up their exercise program. That's a natural tendency, especially if they, again, tend to be short of breath when they take some time off of exercise. But now they take a bronchodilator, in this case, better known as Spiriva, and that becomes an adjunct exercise. It's a bronchodilator. And a lot of bronchodilators have somewhat this same response, but this was a wonderful study, again done by Rich Gaspary's group. And it showed that not only did the curve not seem to sag as it did without the bronchodilator, it actually seemed to increase a little bit. And we might be reading a little bit too much into this, but anyway, there's a lot of benefit to exercise with the adjunct of the bronchodilator. Now, the group in Canada, run by Dennis O'Donnell, for those of you who have been following the research, showed the exercise is good. Exercise plus oxygen is good, actually better. Exercise plus bronchodilator is better. But if you add oxygen and bronchodilator to the exercise, then you can actually increase beyond that. Now, you know, think about cardiologists, what cardiologists have to work with. When they do studies on blood pressure, if you have a 5% improvement in blood pressure, this very expensive medication becomes an acceptable medication because of 5% improvement. You can see that these kinds of improvements here could be 40% improvements. But wait, there's more. For the first 20 people who call, there's pursed-lip breathing. Now, pursed-lip breathing is when a person breathes in through their nose and out through their mouth, and they purse their lips, and what they do is they smell the roses, blow the candle, causing it to flicker. And it's a very, very mild maneuver. It's not, it's smell the roses, blow the candle. And what that does is it increases their oxygen level. Why? Because it bypasses some of the dead space of the upper airways. Anybody wants to know about that, see me afterwards. But anyway, it lowers shortness of breath, and it reduces the amount of work of breathing a person does per minute. It reduces pulmonary hyperinflation. So you have all these things that really are helpful to exercise, adjunctive to exercise, and good in their own right, be able to help people with COPD. So people don't have to become sedentary. Okay, we did a study at City of Hope years ago, published in 1986, that showed that we could use the oximeter, a little oximeter device. I think I have one in my pocket. Except the oximeter that we used was about this big, and it would weigh about 15 pounds, sat on your desk. You had to plug it in. But we used it as a biofeedback guide to pursed-lip breathing to increase the oxygen level. So when they didn't do pursed-lip breathing, their oxygen, their saturation was about 90%. And when they did do pursed-lip breathing, the saturation was much higher. And it works as long as you do the pursed-lip breathing maneuver. It stops when you stop using that maneuver. Now, shifting gears. Remember we're talking about exacerbation or flare-up? Well, it's acute on top of chronic. A person might be going along very well for a while, and then all of a sudden, you notice that they can't breathe as well for the same amount of activity. Very important concept. Breathing as well for the same amount of activity, like walking out to get your newspaper and get the mail. And what happens during a flare-up is these airways become obstructed. They become obstructive because they become swollen, they become full of secretions. You think of an infection as something that you have antibiotics, you get better. But it also can be a destructive process. and can cause the disease to progress, get worse. So you have obstruction, inflammation, which is this swelling along the linings of the airways. Actually, it's the whole process. And infection, and then damage along the linings of the airways. So, and another exacerbation or flare-up is more likely to occur. Our job is to get back to this point as rapidly as possible so we can prevent that damage from occurring. That's the concept. Well, people who have frequent exacerbations end up having more rapidly developing disease, more rapidly progressing disease. And so exacerbations lead to disease progression. It will actually lead to disability, lower quality of life. Another exacerbation is more likely. And they're more likely to die, especially if they get hospitalized. One of the studies showed that they have a 12% chance of not making it from the hospital. So we've got to prevent hospitalizations. That would be a great goal. And it's a higher cost, of course. So that's the downside. Well, what could be the upside? Well, early intervention, you can have more rapid recovery, prevent hospitalizations, prevent disability, and prevent another exacerbation, and lower the cost. So that's the concept. Now, so for COPD, how the patient manages at home makes the difference, makes all the difference. It's got to be consistent, it's got to be persistent, timely, and for example, you know, if you take a look at a cross-section of a population of not only COPD patients, but a lot of people with chronic illnesses, they only take their medications about 50% of the time as prescribed. And inhalers, it's abysmal. Most people, including health professionals who have the disease, have COPD or asthma, only take it optimally 5% of the time. And then oxygen therapy. People don't take their oxygen full time either. They take their oxygen off to go to the bathroom or to go to the kitchen. And that's the time they need the oxygen the most, when they exert. So our job is to help the patients manage and understand what they're doing. Now, so for COPD, we say to the patients, your job is self-management. Our job is to make sure you do your job. So in COPD management, this is kind of the crux of what we have the patients do. They got to get up in the morning and get dressed. They don't stay in their pajamas or night clothes. They take their medications as prescribed, and we've got to reinforce that all the time. They cough and clear secretions. Those patients who have a lot of secretions, we help them to cough more effectively. Because certainly when they have flare-ups, exacerbations, a weak cough is a very bad thing. The cough is what actually clears those secretions and clears the infection. Pursed-lip breathing is very helpful in the ways I was describing. And then we have the patients walk on a daily basis. Now, after the walk, they check for a flare-up. Why? Because if you take a look at people with COPD, they're sitting around the room, they're not short of breath. They've got a disease that causes them to be short of breath, but they get short of breath on any exertion. So they were well aware of what they were able to do yesterday's walk, and then all of a sudden today's walk, instead of being able to walk for 30 minutes, they couldn't even walk for 10 minutes. And they're starting to develop secretion. When that happens, they get involved in the rapid action plan, and we're available to them for that. So they call the doctor, they start their prednisone, which is there in their medicine cabinet all ready to go. Antibiotics, same thing. We like azithromycin, by the way. And bronchodilator, we like Condiment because it has two kinds of bronchodilators in it. And pursed-lip breathing, make sure they have their fluids. And turn on the oxygen, make sure that those saturations remain in the low to mid 90% range. Now, a lot of people don't like to take prednisone because if they take prednisone, it makes them look different. Now, who would want that? And of course, we teach them about their heart and their lungs, a little bit about their anatomy, so that it gives them some feeling as to what is going on. I hope you like this slide because it's very expensive. I filmed it on location. And of course, how to take their inhalers. This was showing with the aero chamber. Very painful slide to do. And getting the medication to where it needs to go. That's a major, major problem. Under the best of conditions, you get about 19% of the medication to go where it needs to go. The rest of it is wasted. It's swallowed, and it goes through the GI tract. And of course, recognize a change in the secretions. Either they now have secretions, or the secretions are changing in color, consistency, and maybe harder to cough up. This was one of our respiratory therapists. She was amazed when she saw this. We animated a picture of her. And of course, now, if pulmonary rehabilitation is a vehicle, and we use pulmonary rehabilitation tools, then exercise is the engine that powers that vehicle. So training, how people learn in our situation, how people learn is not how they just sit around in the class, they learn about things, and then they go home and try to practice it. We actually practice skills. It's more like riding a bicycle, or hiking, or doing something that involves a skill, riding a unicycle. So learning is an event. It's not an event, it's a process. And the process has its ups and downs, and the right direction. So as the disease worsens, patients get more effective at managing their disease. It's not like school, it's like the practice school, in this case practice of medicine. So our doctor's office visit basically does what the patients are doing at home, but we monitor them and reinforce them and get them better at doing those things. And the doctor makes rounds at the end and bills for an office visit, because we can do this because it's in a group setting. So our outcomes are, over 11 years, we've had 154 patients in our group. 112 participated. 81 of them had over 1,100 exacerbations that we monitored. And 45 of them ended up as hospitalizations. That's actually 3.9%. So there were two comparison studies, which I'll show you on the next slide. This is one group that showed that exacerbations led to hospitalizations about 27% of the time. Same with this particular group. And these studies were done for different reasons, but we were able to glean this information from those studies. Well, in our 1,166 exacerbations, 45 ended up as hospitalizations. So in the other two groups, it's 27%. In our groups, it's 3.9%. So we can make a big difference. And we've been monitoring and presenting this yearly as we progress in society meeting. So when a patient has a choice between letting the disease take its natural course, we do something different. And this lady, for example, is a lady in Denver. A lot of people with COPD know about her. Her name is Roxanne Cole, or Lynn, and she is just completing a half marathon. She's 73 years old at this time, and using oxygen at 15 liters per minute, which is a very big dose of oxygen. This gentleman, this gentleman is Mike McBride. It's the first COPD patient to complete the Boston Marathon. Again, 15 liters per minute liquid oxygen. The good support team. And this is the group in Denver that live to exercise. And that is their passion. And they do very, very well. And it translates into a better quality of life for them. So, we have, in summary, basically the disease is chronic and progressive. It will get worse over time. But all components, including comorbidities, are treatable. Patients can live active lives. Emergencies are preventable. Hospitalizations are preventable. And the clinical course of this disease, how it affects the patients, can in fact be modified. So I will end with this slide, which describes our respiratory support group, where they, instead of lying around in their pajamas, they're having lunch, listening to some very bad jokes, and listening to some good entertainment, and even learning something in the process. So thank you.